Okay. All right, patient care, inadequate breathing, assisted ventilations with supplemental oxygen. So obviously, if your patient is not breathing adequate, right? They are not breathing adequate. That means that they're not breathing adequately enough to sustain life. So with that being said, do you think you might have to help in assisting with ventilations to sustain life? The answer is yes, right? So if they're breathing inadequately, that means if you ever see your patient is not breathing adequate enough to sustain lives, that means you have to assist them because they're not breathing enough for themselves. So your options here are going to be as an EMT out in the field is your pocket face mask, which we went over the first 2 days, right? How to use that with supplemental oxygen. So some of these face masks that you have have like a little, I don't even know what to call it, but like a little prong sticking out of it, and you can hook up your O2 to that to even give them more oxygen on top of what you're delivering. And obviously, if for a bag valve mask, there shouldn't be more than you can only use the BVM technically if there are 2 or more rescuers. All right. So if you're by yourself because your partner had to go to the rig real quick or had to go do something, call for backup, you're only going to use your pocket face mask. Okay. Now when it's you and your partner and even more rescuers, you shift over to the BVM. And that just has to do with the fact that the American Heart Association doesn't think that it's efficient enough for one rescuer by themselves to use the bag valve mask, as far as like time goes and stuff like that.
Why couldn't you just use a non-rebreather? Is this for like a patient who is who's already passed away, or is this?
Yeah, so that's a good question. So that's what it comes down to. So your patient. So if you're using a pocket face mask or a BVM, a bag valve mask, it's because your patient is pretty much to the point that they can't breathe adequately on their own. So this patient is gonna be either mentally altered, unconscious, or about to crash. Like you're seeing this patient actively decline. You know what I mean? Like that's the kind of patient.
Yeah, I got it.
Yeah.
Okay.
Yeah, now if you have that patient that is having difficulty breathing, or they can still talk to you, even if they're catching their breath, but they're not mentally altered and they're not passed out, then that's the patient that does get the NRB because they're not mentally altered, they're still communicating. Yeah. Does that make sense?
Okay. Yeah, thank you.
All right, cool. All right, so adequate and inadequate artificial ventilation. So for your adult patients, you want to breathe for them 12 per minute. So that's one every roughly 5 seconds. One ventilation every 5 seconds, right? Now for your pediatric patients, it's 20 breaths per minute for infants and children. Who can tell me why there is a difference there? Why that difference exists?
Because children and infants breathe more normally by themselves.
They breathe at a much faster rate than adults. And the reason is because they're not as efficient as we are. So our bodies, when we grow up, they're more efficient with oxygen. All right. So we don't need to breathe as much per minute. Pediatrics don't have that. They need much more intake of oxygen to fill their bodies up. Because they also have less volume in proportion to us. By volume, I mean blood in proportion to us. And because of that, we need to provide them with more oxygen. Okay, because they're used to getting more oxygen per minute than we are because they need it. Okay, any questions about that at all? No? Okay, now the one thing you don't want to do is you do not want to hyperventilate your patient, your adult patient. Hyperventilation, hyper again meaning too much or higher than, and ventilations are your ventilations. So hyperventilations just means that you're breathing for your patient higher than normal, like too much. And there are only certain times and certain scenarios where hyperventilation might be acceptable, and that's during head trauma situations. And we'll talk about that more when we get to that head trauma chapter. But I just wanted you guys to know that there are certain scenarios where it may be ideal to hyperventilate your patient, but on a normal, you don't want to. All right. What is this called right here? This position?
Tripod.
Tripod. Yes. So the tripod position. What happens is when you're having difficulty breathing as a human being, is that your body it's automatically going to shift into survival mode, and it's instinctual. So what your body is doing by going in tripod is that it's lining up everything. It's lining up your airway and your mouth. And you're also leaning forward to allow your accessory muscles to just do their job and go outward and upward. When your traps go upward, your back goes outward. And that's what the body is doing when this is happening. This is an obvious sign of someone catching their breath, whether it's a medical condition or they just had a really good run. All right, so now we're going to OPRT. And this right here falls under the secondary assessment of your medical assessment. So onset, so when did it begin? That's just good to know for timing. Provocation, what were you doing when this is on? So the reason that this provocation question really helps you out is because it lets you identify whether maybe it's the difficulty breathing is from exertion. Were they working out? Maybe they're not used to working out, or was it just a sudden onset? Did it just happen? And that really matters as far as medical treatment. Quality. Quality when it comes to breathing and difficulty breathing is more of what you see. It's more objective than subjective. So it's not really what the patient is feeling as far as breathing goes. When it comes to pain, it's a little different. But as far as breathing, you have to shift over to objective, and it's what you see. Is the patient coughing? Are they bringing anything up? Any sputum? Any mucus? Anything of that nature? Radiation, you just want to know if the discomfort is shifted anywhere else, just to kind of give you a better idea of what's going on. You know, maybe lead you in a different direction than what you're thinking, because we do get that tunnel vision sometimes as medical providers. We have this one thing in the back of our head, and we just think it's that because we're taught a certain way, but sometimes it's not.
I thought provocation was like, say for instance, it's if they're doing something that makes it feel any worse to their body.
Yeah. So it's a little bit different when we're talking about respirations, because it's kind of like so OPRT is really good for pain. OPRT is really good for your cardiac patients. It's tailored for a cardiac patient, but they also want to use OPRT for breathing emergencies. And I think the only reason this is really done is just to kind of standardize the NREMT testing. Does that make sense? But but the way you were thinking is exactly the way you should be thinking. And OPRT is perfect for your cardiac patients, and it's tailored for cardiac patients. This is more like we just want to make it work, you know?
Perfect.
Gotcha. All right, so severity. Now, on a scale of 1 to 10, I guess the discomfort for the patient. Now, this obviously is not gonna help you out that much because it's more of what the patient feels, and everyone feels things differently. But it helps you because it lets you know if the patient is getting better or worse or staying the same. Because based on how they feel when you ask them this question initially, when you reassess them, did they get better or worse? And that's really how this helps you as far as patient care goes. Time, how long have you had this feeling? And again, this goes back to they're trying to make it fit, because time and onset are the same thing. But you know, just the way it is.
So for critical patient, how often are you taking vitals for? Like would it be for a critical patient? Would it be like every 5 minutes or every minute?
Yeah. So for like test purposes and stuff like that in NREMT, every 5 minutes at least. But in real life, you're gonna have some patients where like you just instinctually know, like, I gotta watch this dude like every minute or else he might die on me, you know. But no longer than 5 minutes. No longer than 5 minutes. Yeah. So patient's position. So observing altered mental status. We talked about that, so I'm not gonna talk about altered mental status. But if you guys have any questions about any of these things, and I'm not talking about them, just ask me, okay? Patient's position, tripod, again, that's the body's just natural reaction to having difficulty breathing. Sitting with feet dangling, leaning forward, to me that sounds just like the tripod position, except you're sitting on something high. So, all right, guys, let's take a little